Hi everyone, and welcome to your 2019 mandatory CME. Today we'll be going over the module involving IV and IO tips for the pediatric population. We'll be focusing on challenges that encompass performing these interventions. I'm Dwayne Cattell, one of the pre-hospital emergency care specialists. Our objectives today consist of a review of the IV and IO directives based on the current ALS PCS version 4.5 directives. We'll do a quick review on blood pressure calculations for the pediatric population, defining what constitutes hypotension versus normal tension. We will review the contraindications for both IV and IO directives. We will talk about the medications that can and cannot be administered through the IV and IO access points. We will look at some challenges starting an IV on a pediatric patient and how to rectify these challenges. And finally, we will discuss the anatomical differences for IV site selection in pediatric patients. Please note that this module covers both ACP and PCP scope material. Primary care paramedics may choose to fast forward through the ACP level content. The last 5 slides of the presentation are regarding IOs. As this is ACP only material, PCP paramedics may choose to stop the presentation at this point. For PCPs working in ACP services, this information may be useful to help further the understanding of the ACP scope of care while working with an ACP partner. When looking at the indications for IV initiation, it states there needs to be an actual or potential need for fluid and or medication administration. For PCPs, the patient needs to be 2 years of age in order to initiate an IV. For ACPs, it's birth and greater. Contraindications for IV initiation for both PCPs and ACPs is a suspected fracture proximal to the IV insertion site. Although not a contraindication itself, but consistent with our teaching and with best practice, we should avoid IV initiation in areas where infection is noted. We want to stay away from sites that have been previously used. There's sclerotic sites where there's scar tissue developed areas, and areas that are hard upon palpation, which may represent a tendon. A vessel that pulsates is probably an artery, so don't try to cannulate that area as well. It is worth noting that fistulas and shunts should be avoided, and the opposite extremity should be used for IV cannulation. We can note that the PCP infusion and bolus rates, which are on the left, are identical to the ACP directives, which are on the right, with the caveat that the ACP scope of practice allows for access through the IO and CVAD for fluid administration. The maintenance infusion rate for TKVO for a patient less than 12 years of age is 15 mils per hour. The maintenance infusion rate for TKVO for patients 12 years of age and greater is 30 to 60 mils per hour. The fluid bolus rates for hypotensive patients is 20 mils per kilogram to a maximum of 2,000 mils based on their weight. Remember, once the patient becomes normotensive, to complete a minimum of 100 ml bolus in pediatric patients and 250 ml bolus in adult patients, as long as there are no signs of fluid overload. It is important to note that patients between the ages of 2 and 12 with suspected DKA require a base hospital physician order via mandatory patch point before the administration of IV fluid. So normal tension and hypotension are calculated as follows from the Advanced Life Support Patient Care Standards Manual. Normal tension is a systolic blood pressure of greater than or equal to 90 plus 2 times the patient's age in years, whereas hypotension is defined as less than 70 plus 2 times the patient's age in years. And we want to make a note that this is for up to age 10. After this, use the adult conventions of hypotension being less than 90 millimeters of mercury torr systolic. Now we're going to look at what medications are approved for infusion through the IV. The medications that are approved for IV certified primary care paramedics to administer at this time through the IV are dimenhydrinate, diphenhydramine, naloxone, 10% dextrose or 50% dextrose, ketorolac, and IV fluid, which is 0.9% sodium chloride. The medications that are currently approved for IV administration for ACPs include epinephrine, specifically 1 to 10,000 concentration, amiodarone, lidocaine, atropine, midazolam, dopamine, adenosine, calcium gluconate, sodium bicarbonate, morphine, and fentanyl. So what's one of the biggest obstacles we face with the pediatric patient when starting an intravenous? You got it, it's fear. You have this person dressed in bright yellow and blue coming at you with a needle. Not the most pleasant memory to have. Fear is probably the most common challenge with children. They don't know us. Couple that with being in pain or very sick, the last thing the child wants is to have a stranger come at them with a sharp object, especially a needle. Keeping the child calm is always a challenge. Children will be upset, and in their minds this is the worst day of their life. Children, as with adults, want to be told the truth. Children are very good at seeing through someone who is not truthful. Restraining children is not something that anyone wants to perform. And with all of this, communication with the child can be one of the most challenging of the challenges itself. We need to remember that all children are different, and this is not a cookbook approach. But some of the ways that we can help overcome these challenges with starting IVs on pediatric patients are by, first, establishing and building a rapport with the child when time affords this. Try a few simple things such as showing them how the tourniquet goes on their parent or their caregiver. And we need to let them know everything that's going to be taking place, again, when able. And we need to ask permission with every single step of what is going on. Next, we want to keep the child calm. All children are different and some will have more anxiety than others. Use the tools and comforts at your disposal, such as having the parents with the child at all times, give them their favorite toy, or to provide some type of distraction. Being honest with the child is the best policy. If it is going to hurt, tell them it'll be uncomfortable, but brief. Explain every step of the process to both the parents and the child so there will be no surprises for them. Restraining a child should only be done as a last resort and only when absolutely necessary. And we need to ask ourselves, is this IV really necessary? Can I give other medications, and can I substitute those for the IV meds? Sometimes using a splint on the opposite side of the IV will help stabilize that IV and reduces the risk of being pulled out and further harm to the patient. Communication with the child is different than with the adult. Gear the questions to the developmental age of the child. Have the parents present at all times for all interactions with the child and use them to help communicate what the intent is. When we look at anatomy of the child, one of the unique challenges that we cannot modify directly pertains to anatomy. Depending on the age of the child and their stage of development, the younger they are, there's a higher chance that they will have a thicker layer of adipose tissue. This makes finding the veins difficult, and therefore time needs to be taken to ensure that we find a great access point. The pediatrics veins can seem to be deeper because of this, and as a result our angling of the IV may change to become steeper to make access easier. The anchoring points may need to be farther back to prevent these deep veins from rolling as well. Is it better to use the hands if there is an AC sticking out at you? Not at all. We should always look distally first and then work our way proximal. If you want to try for the AC first, that's fine, but if we blow the AC vein, everything below that is considered to be compromised, which therefore deems to go to the other side. Children, as with adults, don't like for the most part to get poked. It may be better to access the AC if it is there and seems straightforward to access, as we may not get a second chance to attempt another IV. As discussed, pediatric patients can have relatively more adipose tissue, making IV insertion more difficult to palpate the veins and a steeper angle required to access the vasculature. Note that the distal to proximal rule still applies. The reason being that if the proximal AC is blown, those veins below are also blown. However, every situation is unique, and in the extremely hesitant child, it may be better to access the AC if it appears the most promising, as we may not get a second chance to attempt an IV. You may have seen other sites used in the hospital, such as scalp veins or umbilical veins. In the pre-hospital world, only those sites accessed in adults should be cannulated in pediatric patients. Okay, now let's move on to an intraosseous review. When looking at the indications for initiating an IO, it states that there needs to be an actual or potential need for fluid and or medication administration, as well as the inability to establish an IV in the child, and the child is either in a cardiac arrest state or a near arrest state. The child has to be less than 12 years of age for the pediatric IO directive, and the contraindications include fractures or crush injuries or a suspected or known replacement/prosthesis proximal to the injury site. The reasons for the fracture and crush injuries are that of the IV so as to assume that there is vessel damage and to avoid having medications and fluid become interstitial, and the prosthesis is due to the placement of the anchoring point in the proximal tibia, which is located or can be located where the IO needle would be established, therefore rendering the IO needle non-functional. The discussions in establishing an IO in a pediatric patient would surround and involve the parents or caregivers. The child will either be in an arrested state or very close, which would render them with an altered level of awareness. Let the parents know why this is taking place and what to expect both on scene and in the emergency department. The medications that are currently approved for IO administration for ACPs include epinephrine, specifically 1 to 10,000, amiodarone, lidocaine, calcium gluconate, sodium bicarbonate, and IV fluid, 0.9% sodium chloride. The reasons we do not administer all of the medications that we can through the IV are, first, the directives only speak to the IV route for certain medications. Second, the patient is either in an arrested state or a pre-arrest state, and therefore only the resus medications are to be administered. And third, some absorption rates are variable, coupled with the concern of certain medications going interstitial that can cause damage as a result. The challenges are not with the patient. Remembering that the patient is very, very sick, and in most cases VSA upon our arrival. So the problems that are associated with fear or anxiety are not there. The challenge lies with the parents and the caregivers. We have to remember that this child is not doing well, and when this happens, the parents or caregivers have a high level of anxiety and stress due to the situation, and when they witness a drill being pulled out, they tend to be questioning what is going on. This is usually done in a more assertive manner. Again, honesty is the best policy when it comes to these type of situations. Let them know that the child is very sick or in cardiac arrest. Use language they can understand. We need to have reassurance that we need this access for life-saving medications, and it is needed at this point. And sometimes asking them to stay out of the room while the resuscitation is happening is the best option, but usually this does not happen. Explaining step by step of what will happen prepares the parents and caregivers. Remember that the only approved IV site for pediatric, the only approved IO site for pediatric IO access is the proximal tibia, and that we don't want to delay transport of these patients, and it may be more prudent to obtain access en route. This is completely situation dependent. Again, the approved IO access site is the proximal tibia. So when we're landmarking, we want to feel for the bump below the patella, and this is the tibial tuberosity. We want to measure 2 finger breadths below on the medial or the flat aspect of the tibia, and then the insertion angle should be at 90 degrees. The needle insertion point should be seated in the medullary sinus, as this is where the blood flow is. With the Easy IO system, the pink IO needle is for patients between 3 and 39 kilograms. The blue needle is for patients 40 kilograms and greater. And just a note that the blue needle can be used in the absence of the pink needle if necessary, as there are 5 millimeter marking lines that are situated on the needles themselves. It'll be a case of insertion will stop between those marking lines. The yellow IO needle is reserved for the adult population, who tends to be somewhat corpulent. This is due to the excess adipose tissue that the needle needs to drive through to get to the osseous tissue itself. Remember to anchor the limb, but keep your hand away from being directly behind the insertion site, because if the needle goes through the anterior aspect of the bone and out the posterior aspect of the bone, we don't want an inadvertent needle stick. Once the IO needle is established, attach the IO extension set that you have previously primed. Aspirate back for blood, marrow, and clots. If present, we're in the right spot. Flush the line, the needle, and secure it into place. If available, and this is all service dependent, use the IO stabilizer. Run the fluid with the aid of a pressure infuser, and this usually flows well at about 300 millimeters of mercury torr. Well, thanks for watching this presentation, everybody. And if you have any further questions, please do not hesitate to contact me directly. You can find my contact information on our website at www.lhsc.on.ca/BHP.